Hello, dears, and welcome to Al-Hussaini Virtual Lab, Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a rare variant of appendiceal neuroendocrine tumor, formerly known as carcinoid of tubular type. So this is a case of a 56-year-old male patient who presented with long-standing periumbilical abdominal pain, and then on investigation, he was found to have an appendiceal mass. So he underwent appendectomy. And as you can see here from the low power magnification, this is the appendiceal mucosa, and then the wall is diffusely infiltrated by those small tubules, dispersed tubules or glands. And the first thing that would come to mind is this an adenocarcinoma or not. And this is on higher power magnification. And as you can see here, very well-formed tubules or glands that are seen infiltrating among the wall, eliciting some degree of fibrosis. And here also very well-formed glands. Now the nuclei are vesicular with small prominent nucleoli, but definitely the nucleoli are clear. And as you can see here, there is actually intraneural invasion, common feature of tumors in general and in neuroendocrine tumors in particular. So this is a common feature of neuroendocrine tumors. And as you can see here, very well-formed glands or tubules. And honestly, the first thing that would come to mind is this an adenocarcinoma. Now, tubular neuroendocrine tumors of the appendix are extremely rare. This is why you should always keep this important differential diagnosis in your mind. One important feature that is usually seen in appendiceal neuroendocrine tumors in general and tubular neuroendocrine tumor of the appendix as well is the pseudo-vascular invasion. So this is not a true lymphatic permeation, it's a pseudo-retraction of the tissue because of the fibrosis around the glands of the tumor cells, which really would induce the idea of probable lymphatic invasion or permeation. If we're not sure, we can do vascular markers like CD31, CD34, or even D240 or podoplanin in order to prove whether these are lymphatics or not. But this is a common phenomenon with the neuroendocrine tumors in general, including the pancreas, is the retraction of the tissue because of the amount of fibrosis that is elicited by the tumor actually. And this is the most important immunohistochemical marker to render the diagnosis chromogranin-A. And as you can see, it's really everywhere. It's diffuse infiltration of the wall of the appendix by the chromogranin positive tubular appendiceal tumor, and this is on high power magnification where we see beautifully the positivity with the chromogranin. And frequently actually a chromogranin, I always tell my residents that you have to go on high power magnification before saying whether chromogranin is positive or negative, because quite often it's actually like this one here, just a small intracytoplasmic dot positivity with the chromogranin. But in this tumor, it was a crisp positive staining. And this is another focus where we have the glandular formation, very nice gland, and then we have the chromogranin positivity. And of course, we have always to supplement with another neuroendocrine marker. Synaptophysin is the second neuroendocrine marker, and again, strong diffuse positivity in the glands or tubules infiltrating the wall of the appendix, and this is another focus. Now, importantly, these tumors are frequently more than 90% positive with CDX2. So if you do just CDX2 without the neuroendocrine markers, you will probably mislabel the tumor as adenocarcinoma of the appendix, and you probably will miss that this is the tubular variant of the neuroendocrine tumors of the appendix. The Ki-67 is important to perform in order to help in grading the tumor. You have to do two things. You have to count mitosis and to do the Ki-67, but I honestly rely heavily on Ki-67 because if Ki-67 is low, less than 2%, so probably there will be no mitosis and mitotic figures will be less than 2 per 10 high power fields. So the final diagnosis in this case is well differentiated neuroendocrine tumor that is grade 1 because of the low mitotic count as well as the low Ki-67 proliferative index. It's a special variant that is called the tubular variant. It's the rarest of all types of carcinoid tumors or neuroendocrine tumors of the appendix, and it has a special staging. The staging in the appendiceal neuroendocrine tumors depends primarily, the T component of the T and M stage depends primarily on the size of the tumor, but also if the subserosal fat is infiltrated, then this is automatically, regardless of the size of the tumor, will be PT3 and N0 because the tumor was, lymph nodes were submitted and they were completely negative. So remember that tubular appendiceal neuroendocrine tumor is a rare variant of neuroendocrine tumors of the appendix that can be misclassified as adenocarcinoma of the appendix. So whenever you encounter something that with a very well-formed tubules or glands in the appendix, remember to order two important markers, chromogranin and synaptophysin. If they are positive, they will support that this is a neuroendocrine tumor rather than an adenocarcinoma, with all the different implications for the treatment and the management for the patient. Remember that the grading depends on the mitosis and the Ki-67. Ki-67 is very helpful, at least to determine the hot spots on which you would go and look for the mitosis. And remember that neuroendocrine tumors have a special staging system similar to, but has some differences from the staging system of the adenocarcinoma of the appendix or of the GI in general. So you have to stage the neuroendocrine tumors according to the neuroendocrine staging system, which in a way it takes into account the size of the tumor in neuroendocrine tumors, whereas in general the size of adenocarcinomas in the GI is not an important determinant of the stage like in colon cancer or in gastric carcinoma. I hope you find this tip useful in your daily practice. Thank you.